Thank you, Dr. Winning, for such a wonderful review on EUS, from basic science to management. So wonderful. So our next speaker is Dr. Jason Samarasena, my colleague, a professor of medicine and associate chief of GI and Hepatology Division, UCI, and the program doctor of interventional GI fellowship. Dr. Samarasena, very dedicated interventional GI and interested in endohepatology. He's not just really dedicated for new technology development, he likes hepatology too. So a lot of challenging and inspiring discussion about how to use this to hepatology. And he is actually receiving a big industry, multiple center studies on endohepatologists. He's going to talk about clinical application of endohepatologists. Jason?
Thank you very much, Dr. Hu. You know, it's always a little nerve-wracking being the last speaker in a hepatology session and being an endoscopist. I am really honored to be here. And I think, you know, an endoscopist being in a hepatology session, you know, maybe says something about, you know, the work we've done, and I'm really proud to be up here. So these are my disclosures. You know, I think we can all appreciate the level of liver disease burden in this country. And, you know, there's really been a growing number of endoscopic procedures that are pertinent to liver patients, particularly surrounding endoscopic ultrasound. And my mentor, Kenneth Chang, and I wrote this chapter called Endohepatology, New Paradigm, the integration of endoscopy within the practice of hepatology, you know, with the sideline, making the liver cool again. But I know already the liver is very cool, and, you know, so, you know, don't throw anything at me, Dr. Lumba. And there's, you know, part of this chapter 12 years ago, we sort of maybe foreshadowed what potentially could be achievable by an endoscopist. And so EUS-guided variceal interventions, EUS-guided liver biopsy, EUS-guided elastography procedures, and EUS-guided portal pressure diagnostics and potential interventions. So I'm going to talk about these four things, and we'll start with the EUS-guided interventions for variceal bleeding. So in most of the country, most of the world, the management of gastric varices is with a direct endoscopic puncture. Sometimes that works out. Sometimes, as you can see here, it hasn't worked out that well. And with EUS, there may be potential advantages. One is better assessment of the size and morphology than EGD. You can use Doppler to evaluate flow, and it doesn't require any luminal visualization. You can just see it with the EUS, more accurate delivery of glue. One of the disadvantages, though, is systemic glue embolization. And so to mitigate this, we kind of stole these from our interventional radiology colleagues. These are essentially coils made out of soft platinum with synthetic fibers to promote clot formation, and you can basically put that through the EUS needle. And so this was one of the larger studies, 152 patients with gastrofundic varices, done by Dr. Binmuller's group. And in this video, you can see we can accurately measure on endoscopic ultrasound how big the varices are. We're using a 19-gauge needle to puncture the varices and basically deploy the coils before the glue is injected. So based on the size of the varices, you can assess how large a coil or a number of coils that you need, then injecting glue. Here you can see that there's still some flow in the additional varices, and again, repuncture, additional coiling, and then additional glue. And once EUS is confirmed obliteration, then you essentially stop. And in this study, basically the bleeding rate after these interventions was extremely low. One of the issues that we get into is there isn't any commercially available glue product that you can inject through a needle very easily. And so my colleague Marvin Yu at Brigham Women's found that gel foam, which is available really in any OR, you can just basically cut it up into kind of little pieces, mix it with saline, and you essentially make this gelatin slurry. And now a lot of us have actually switched over from glue to this product, and it's very, very easy to prepare and inject. More studies coming with regards to this. But essentially, you know, the quick take-homes from EUS-guided variceal interventions right now, EUS seems to be a better assessment of size morphology. We can use Doppler to evaluate flow. It doesn't require luminal visualization. The gelatin sponge slurry may be better than glue. One of the issues that we're having, there really isn't any standardized training for this procedure. So one of the special interest groups that I'm chairing is looking into sort of models and training modules for this. But whenever we have a case of gastric variceal bleeding, we always discuss it with our interventional radiology colleagues. Depending on your institution, IR may be extremely strong in this area, like it is at UCI, and as a result, most of the variceal management happens with interventional radiology at our institution, and I talk with colleagues where it's really not the case, and the endoscopists do a lot more of this work. EUS-guided liver biopsy is something that we at UCI have been working on for quite a long time. There's been a bit of an evolution. I remember, you know, doing percutaneous liver biopsies with Tim Morgan at the VA for forever, and you know, we used to, you know, stick the needle in, and the patient would be kind of on their right side for a couple hours, and then on their back for a couple more hours, and now interventional radiology has largely taken over this domain. But some potential advantages for endoscopic ultrasound, you can really do the procedure regardless of body habitus. It's possibly less painful. It's an image-guided approach that allows for avoidance of blood vessels, because on endoscopic ultrasound we can just basically shift the scope so that we avoid vessels, and we can access a wide segment of the liver parenchyma, and we can also hit the left lobe and the right lobe. The minimal measurements by various liver societies say that we should at least get a 2 centimeter length and at least greater than 11 complete portal tracts. So one of the original prospective multicenter studies on this had 110 patients, use a 19 gauge straight needle, and one of the big kind of questions that have come about is, what is the technique for obtaining this biopsy? You can use the same needle, use a different type of suction technique, and get a completely different result, as we'll see. So in this early study, the median aggregate length was 38 millimeters, and the median complete portal tracts was 14. So off to a pretty good start. This was a group, this was a study done by Marvin's group that looked at ex vivo human cadaveric tissue model. They looked at 6 different needles, various techniques, and looking at you know, how these different needles and techniques performed. They ended up doing 288 liver biopsy samples, and essentially 3 fanning passes was better than 1 pass, and dry suction showed no difference between what we call 10 slow pull technique, where you're basically slowly pulling back the stylet as you're doing the FNA, or putting 10 cc's, 20 cc's, or 30 cc's of suction. In terms of the needle type, the needle type on the left seemed to work the best. This was a new fine needle biopsy needle, and this needle tip type seems to be better than the traditional FNA needle. The other question that's really come about is whether something called wet suction versus dry suction has been helpful. And so in this study, this was 40 patients. Each patient had 3 successive passes, each with a different suction technique. First was a control dry, then was a dry heparin, then there was a wet heparin. And essentially this wet heparin technique was much better. So we did a study looking at 2 specific fine needle biopsy needles. We randomized them to left and right, and as also the which needle we started with, and used a single actuation method, so just one actuation in the needle, in the liver. And we found that this Francine tip needle did a better job than the fork tip needle. Even with one actuation, we were actually able to get a very high yield. I'm going to show you this new dynamic suction technique that we just published. And you know, Dr. Hu has been very patient with us over the years, as we sort of kind of iterated and reiterated this technique to get to this point, which I think really is the best technique for EUS-guided liver biopsy in the world right now. And I've been to many kind of meetings over the last year and sort of have demonstrated this, and people, you know, are very impressed with the yields that they're getting now after adopting this. So very, very just simple modification to what we've been doing for a long time. But here you can see Dr. Shang with the F&B needle. Here, our nurse is actually going to take off the syringe for the first throw. And it's going to be one throw. We're going into the right liver here. And then we put the syringe back on. We open the suction and then close the suction, just 2 seconds of suction. And then we pull back to about 2 centimeters from the liver capsule. For the second and third pass, a little bit different. We leave this syringe on, and then we basically open, throw, and then close. And it's the same thing for the third pass. And these are just very, very simple modifications of things that, you know, we've been doing as endosonographers. And but this sequence seems to be by far the best. In fact, I think the fact that we take the syringe off for the initial throw, and there's now sort of a kind of an open channel for the liver tissue to go up into our needle, I think that's probably one of the biggest keys of this. So in our study, which is now actually extended to almost 100 patients, we've had 100% technical success, but our lengths are much longer, 6.74 centimeters. Our average complete portal tracts are about almost 24 per biopsy sample. And now, you know, with Dr. Hu, I think he's much happier with the samples that we're giving him and Harry, and so I think now we're, you know, pretty much getting this sort of stuff on every liver. So so in summary, you know, this has been kind of a long time coming, but we've learned that the new core needles, definitely better than the straight needles. Pain appears to be maybe a little bit more with the core needles, so something for us to maybe anticipate. Single actuation may be enough, but 3 is likely better. A fanning method is helpful. Longer excursions lead to more tissue. And it seems like we're able to get longer excursion in the right liver than the left. The heparin prime needle with this new wet suction, this dynamic wet suction technique is likely the best. Something very new that we've been leading is something called Shearwave elastography. And so FibroScan, or vibration control transient elastography, is really sort of one of the mainstays in the management of patients with liver disease. There are some limitations to it. With EUS, some advantages may be real-time liver visualization allows the operator really to select an optimal spot for measurement. It can be performed in patients with morbid obesity or narrow intercostal spaces, and both the right and left hepatic lobes can be assessed with EUS Shearwave, as well as spleen elastography. This is on the new EUS processors, the Ariad 850. We can basically get a screen like this. We usually get 10 measurements, and then we get the median elastography measurements, and you can take this region of interest and kind of control the box. And we've done some studies looking at how close this should be to the transducer, not making too many angles, finding the right spot, devoid of vessels, to get the most accurate measurements. And so we did a study looking at comparing basically bilobar liver and spleen shearwave elastography with liver biopsy. And in this case, we use cutoffs similar to what had been assessed in the literature already. And as you can see here, as the kilopascals go up in the right and left liver and the spleen, the sensitivity and specificity increase. But this is something that's very, very easy to do, doesn't take very long. And essentially, when we do an endohepatology workup, we do this on every patient. There's now a 4-center study prospectively that's happening that we're a part of right now. The last topic I'm going to talk about is EUS-guided portosystemic pressure gradient measurement. And I think portal hypertension really does mark the transition to decompensation in a lot of liver patients, and the hepatic venous pressure gradient or portosystemic pressure gradient accurately reflects the degree of portal hypertension as the single best prognostic factor in liver disease. And this measurement is typically performed by interventional radiology via a transjugular approach. There are some disadvantages, the main one being indirect measurements of the portal vein pressure. There's been a few kind of pioneers in this field, Dr. Brugge, Dr. Kantsavoy, and now Dr. Chang. And under the guidance of Dr. Chang, we were able to create a novel EUS-guided portal pressure gradient measurement system with a 25-gauge needle and a compact manometer that you can see here. And this was a really fantastic time for us because we were sort of in the animal lab, and we had our interventional radiology colleagues that you can see their kind of balloon catheter in the right hepatic vein, and our echo endoscope basically measuring the vessel at exactly the right same spot, and the right pane you can see sort of the EUS equivalent of that. And when we got this plot, it was really amazing to see how tightly the measurements were correlating. And so the system is it's very simple. It's we use a 25-gauge FNA needle. There's some non-compressible tubing, and this compact manometer, and some heparinized saline. And so you just connect the tubing up to one end of the manometer. Kind of reset the manometer as everything is level on the table, and then the tubing then attaches to the inlet of the FNA needle. This was the original setup that we came up with, and then you have somebody to kind of hold the manometer at the mid-axillary line. That's usually one of our fellows who we shout at repeatedly during these procedures to hold it still. So now essentially what we're doing is a transgastric, transparenchymal puncture of the hepatic vein. And you can see on pulse wave Doppler the kind of the quad-phasic waveform of the hepatic venous system. For a portal venous reading, we're going transgastric, transparenchymal, usually into the left portal vein, and you can see sort of the venous hum on pulse wave Doppler. And so this is an actual case. So basically puncturing with the 25-gauge needle into the, in this case, the right hepatic vein. And we will now push a little bit of the heparinized saline. You'll see the bubbles on EUS to know that you're in the vessel. What will happen is the numbers will go up very, very high, and then they'll kind of level eventually down to kind of a stable reading, usually after about 30 seconds or so. And then we'll sort of say that's the number we're going to use, and then we flush again, and then we'll repeat that 2 more times for the hepatic venous reading. And we'll take the average of those 3 readings for the hepatic venous measurement. Then we'll take out the needle and access now the portal vein. And the same thing, we'll flush. We'll see a little bit of that those bubbles in the vessel on EUS, we'll know where we're in. And in this case, the median for the portal venous pressure was 26. The mean for the hepatic venous pressure was 12, and this patient had a gradient of 14. So now, not much has changed with the procedure. This is sort of the setup in the room, but as you can see, there's no fellow anymore, and the fellow has been replaced by this very sophisticated stand. And so we don't have fellows in these cases anymore. We really have no use for fellows in these cases at all. Now the stand is doing a much, much better job. So so we have done this was our first human pilot study, 28 subjects, basically 100% technical success in identifying and accessing the target vessels. It's really amazing, when we've done EUS for like 20 years, and, we've just been looking at the liver, and now we're just fascinated by it for the first time. We've got people calling me about learning liver anatomy, and, is this what I'm seeing here? Which segment is this? And I'm like, I don't know, but there's just tremendous interest in the interventional community to learn these procedures, and because I think it's extremely safe, as you'll see. So no complications in these 28 subjects, and essentially what we were able to do is just sort of correlate our readings with sort of clinical subgroups. So there are patients with sort of high risk features for cirrhosis versus low risk, and you can see here the PPG measurements were higher in those high-risk patients, higher in patients with varices, and higher in patients with portal hypertensive gastropathy. So, so we did larger studies. This is a DDW presentation, prediction of liver histology and clinical parameters of liver disease using US PPG, results from a US multicenter endohepatology experience. And, it's always risky when you, submit these things to like AASLD. And so we were, happy to get an oral presentation, but then even happier when we got a Best of DDW award at the AASLD meeting. And so, yeah, came up twice. They just for emphasis. Yeah, so we're so proud. So essentially, this was really to evaluate a correlation between EUS PPG and the clinical markers of portal hypertension and non-invasive markers of liver disease, a lot of which Dr. Lumba had covered earlier. And, I think one of the things that this endohepatology workup is so useful for is diagnosing, the situation of a patient with equivocal kind of data or discordant data. And so essentially, this was a multicenter retrospective study looking at patients who had these non-invasive markers of liver disease, APRI, FIB4, MELD, and transient elastography and liver histology. We looked at gradients greater than 5 and greater than 10, and they were compared to these non-invasive markers and liver histology. And so technical success was over 98%. And similarly to our single center study, there was good correlation between thrombocytopenia, esophageal varices, and the presence of portal hypertensive gastropathy. There was very good correlation with FIB4 and APRI, good correlation with MELD. One of the, I think, more interesting parts of of our findings was there were 39 patients who had all three of PPG, transient elastography, and liver biopsy. And in about half of those patients, the PPG was appropriately less than 5 millimeters of mercury, and that accurately characterized patients with stage 0, 1, or 2 fibrosis, but the transient elastography was falsely elevated. So if you look at the correlation of PPG with liver histology, it actually correlated really, really well. But with transient elastography, there was a lot of overcalls. So this study has kind of shown that, and there's another study that was presented at DDW this year that showed a similar finding. On the flip side, there were some patients that had advanced fibrosis, but really didn't have any evidence of esophageal varices, portal hypertensive gastropathy, no thrombocytopenia, APRI, FIB4, MELD were all low, as whereas the transient elastography with the PPG was slightly elevated. And so we wonder if PPG might be a slightly more sensitive tool to looking for kind of early advanced fibrosis. And so in this study, the PPG greater than 5 was the best predictor of advanced fibrosis compared to all of these, and this was just recently submitted for publication. So I think EUS-PPG really provides direct measurement of both hepatic and portal veins. HVPG is not very accurate in pre-sinusoidal portal hypertension, and I didn't show this, but in NASH cirrhosis, HVPG may actually underestimate the portal venous pressure. So PPG seems to be more accessible and definitely repeatable than HVPG. This is a very, very easy procedure for people doing EOS FNAs of pancreatic masses to learn. In fact, it's extremely easy. And it may be more accurate than current non-invasive markers of fibrosis we'll see, but now there is a commercially available device. It's a very short learning curve, and there's definitely formal training courses. There's ongoing clinical trials. Now, we just concluded the portal study, which was a multi-center international study prospectively collecting this data, involving sites in the US, Hong Kong, and Australia. And I was honored to lead that study. And there's another study called the Encounter study that's actually doing correlation between HVPG and PPG in the same patient. There's been a large following. In fact, I'm proud to say that our current advanced fellow, his name is Andrew Yu, he's done 2 years of general GI. He did a 3rd year in transplant hepatology, and now he's with us to learn endohepatology and interventional endoscopy. And I think there's a lot more interested trainees in sort of learning this aspect to kind of learn more about liver disease. And this is one of the most popular special interest groups of the ASG right now. Dr. Chang has trained hundreds of endosonographers in this technique, and I think our ability to teach this, over these types of sessions is actually quite feasible. I want to just end with showing this picture. This is from the Johns Hopkins website, and I think anybody that's been to the Johns Hopkins website sees these beautiful, images by these kind of medical artists, and so it's hard to believe that in the animal lab 12 years ago we were working on something, and now on the Johns Hopkins website they're sort of advertising and sort of showing that like this is a procedure that they do, and so things have really accelerated really beautifully. And I think now, as an endosonographer, I feel that I can help Dr. Nguyen and Dr. Hu kind of help manage their patient with this sort of endoscopic exam, looking for PHG and varices. I think the Shearwave elastography is something that we're all going to find to be extremely useful. EUS-guided liver biopsies have now evolved to the point that really the specimens are quite excellent. And now with portal venous pressure gradient measurement, I think this is sort of added value. And so with that, I'll say Happy Father's Day, and thank you very much.